Welcome to our podcast, Oncology Morning Commute, From HER2 to TROP2, Evolving Targeted Therapies for Breast Cancer. Morning Commute is developed in collaboration with At Point of Care and Projects in Knowledge and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from AstraZeneca Pharmaceuticals and Daiichi Sankyo Incorporated. In this episode, Dr. Tiffany Traina and Dr. Neil Iyengar continue their discussion of antibody-drug conjugates. They look beyond targeting HER2 and review data on the treatment of metastatic triple-negative breast cancer, HER2 low-expressing breast cancer, and the emerging data on TROP2 and HER3 as new targets for therapy. Information about the faculty and disclosures can be found at morningcommutepodcast.com/solidtumors2. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Traina is Vice Chair of Oncology Care in the Department of Breast Medicine Service at Memorial Sloan Kettering Cancer Center in New York. Dr. Iyengar is an Associate Attending Physician, also in the Department of Breast Medicine Service at Memorial Sloan Kettering Cancer Center in New York. I am Candace Hoffman, Managing Editor of Morning Commute. Dr. Iyengar will begin our discussion.
Welcome to our second podcast on antibody-drug conjugates and breast cancer. I'm happy to welcome back Dr. Tiffany Traina. And today we're going to continue our discussion with a focus on advanced and metastatic breast cancers. Why don't we start off a little bit going back to the concept of what an antibody-drug conjugate is. We talked about this a little bit in the setting of HER2 positive breast cancer. But I think this will be helpful to remind ourselves how an ADC works. Dr. Traina, could you comment on this?
Oh, I'd be happy to. Thanks so much, Dr. Iyengar. So I think from our sort of clinical practice and standards of care over the years, we've been familiar with antibody-drug conjugates like TDM1 and more recently trastuzumab deruxtecan. And these have transformed the treatment of HER2 positive breast cancer, both in the metastatic setting and early stage setting. And so I do think it's worth just spending a moment or two talking about what that construct looks like. So an antibody-drug conjugate, as I think of, has three components to it. The first is the humanized monoclonal antibody. And so we've had bland antibodies treat breast cancer before, and that's what trastuzumab is, targeting HER2. And with just a bland antibody, that has the ability to activate natural killer cells and complement, and it can modify intracellular signaling. So just the bland antibody by itself can have some activity. And the properties that you think about for the antibody, or what is its target, you want to have a target that's highly expressed and differentially expressed. So you want more of that target on a cancer cell than on your normal cells as we think about minimizing risk and benefit. What we're coming to learn is that that particular target may be oncogenic, but it doesn't have to be oncogenic. I think of it as like a mailbox on the side of a house, right? It just has to be there to accept or receive the mail, accept or receive the antibody to that target, but the target itself does not need to be oncogenic. So the second piece of the ADC is the linker. And these can be classified as either cleavable linkers or non-cleavable linkers. They can be peptide or disulfide bond linkers. And so there are ways that you can differentiate an antibody-drug conjugate just by the development of that linker and the properties of that linker. And then the third piece and differentiator is the actual payload. So what is attached to that antibody? And these payloads are traditionally, in our experience lately, cytotoxic agents. Hopefully they're non-cross-resistant. Many times what we've seen is the antibody, the payload in that ADC may not have been tolerable if it was given directly as cytotoxic chemotherapy intravenously. But when you can use just a few molecules and attach that to an antibody and directly deliver it to the cancer cell, you're able to have a much more desirable safety profile. So it also lets us know that there are lots of agents that may have been studied in the past that failed due to safety concerns that might be revisited as a payload where you can have sort of a high drug to antibody ratio, as we've seen some of our approved drugs have ratios as high as 8 molecules of chemotherapy on one antibody or 4 molecules on one antibody. So these are the way I think about ADCs and those three unique components, and something that we'll look at as we talk about the different ADCs in development.
What a fantastic overview and great way of thinking about how these drugs work. I think it's also really exciting the point you made about the potential for reviving cytotoxic drugs that we hadn't really thought about before because of their safety issues. So very exciting. Why don't we shift with a focus on triple negative breast cancer and how the ADCs are coming into play here. But let's start a little more broadly, Dr. Traina, and if you can tell us a little bit about some of the challenges in the treatment of metastatic triple negative breast cancer, especially when some of our targeted agents are just simply not options here, and some of the characteristics that might be helpful when characterizing TNBC and matching the appropriate treatment.
Mm-hmm. Yeah, happy to touch on this. This is an area dear to my heart. My clinical practice is largely women with triple negative breast cancer, and it's a focus of my research program. And I think everyone out there caring for women with triple negative breast cancer, wishes that we had more therapeutic options available, wishes that we had drugs like the HER2 positive space or even the ER positive space, because there have been such tremendous benefits when you have a target and a drug that effectively works against that target. The term triple negative breast cancer is really a big catch-all basket term of tumors that just didn't meet the criteria of estrogen and progesterone expression or HER2 amplification or overexpression. But it really hasn't spoken to the biology of all the subtypes of triple negative that might be out there. And so when I approach a woman who's diagnosed with triple negative breast cancer, and I'm doing air quotes while we're talking, I really find that I immediately need to also qualify what other biomarkers do I know about their germline status, their tumor status, to be able to start thinking about what therapies may be of benefit for them. So reflexively, if I hear triple negative breast cancer, I immediately want to know a patient's germline BRCA1 or BRCA2 status, because that information is actionable. We have FDA-approved PARP inhibitors, such as olaparib and talazoparib, for patients who have germline-associated BRCA1 or 2 associated breast cancer. And those have shown survival advantage. Olaparib has shown survival advantage when used in the first line setting for someone with a germline BRCA1 or 2 mutation. The next biomarker that I think is really mandatory to know is PD-L1 status. And this is critical when we're thinking about a treatment plan for metastatic triple negative breast cancer. The original PD-L1 testing that we did was SP142, and that was a companion diagnostic for atezolizumab. And those patients who had PD-L1 greater than 1% by that assay were eligible for atezolizumab plus taxane chemotherapy. As we all know, the FDA and sponsors have kind of withdrawn the development of atezolizumab in the first line setting for metastatic triple negative breast cancer. However, we do have approval for the use of pembrolizumab in patients in the first line setting with metastatic triple negative breast cancer that test PD-L1 positive. But this assay, this companion diagnostic, is a CPS score. It's using 22C3, and a CPS of 10% or greater is considered positive. So I need to qualify when I think triple negative breast cancer. I want to know what is the PD-L1 status, and I also need to specify by which assay and exactly what was the percent cutoff, because we've seen data recently that it is truly the subset of patients with a CPS of 10% or greater that derive benefit from pembrolizumab plus chemotherapy. I think other biomarkers that I look at to qualify my TNBC diagnosis is somatic tumor sequencing, because we're always looking for those potential mutations that might be actionable, like NTRK alterations or high tumor mutation burden that might allow for use of single agent checkpoint inhibitor. Although we look for these things quite a bit, their expression or their presence in triple negative breast cancer tends to be pretty uncommon. And so our shared experience, unfortunately, is searching for all these targets, but many times being faced with a treatment decision for a patient where we're often left with cytotoxic chemotherapy, which often feels inadequate.
That was so helpful, Dr. Traina. Thank you for that overview. I think that as we start to see newer drugs coming down the pipeline, and we also start to think about biomarkers to identify patients that are potentially eligible for the drugs, this field becomes a lot more complicated as we also introduce the various assays for evaluating these biomarkers. So that overview was really helpful. And it's interesting that we can think about targetable markers like PD-L1, for example. But as we shift to some of the antibody-drug conjugates, some of these targets may not be as measurable. And I think we can start with TROP2, for example. Could you tell us a little bit about what TROP2 is? How is it a target? And is it something we should be looking for? And how this might impact treatment?
Absolutely. Happy to talk about this. This has really transformed our options for patients with advanced metastatic triple negative breast cancer. So TROP2 is actually highly expressed on epithelial cells. And so particularly in triple negative breast cancer, but there's actually also great TROP2 expression in hormone receptor positive breast cancer. And where we're finding great significance, remember I said the target in an antibody drug conjugate does not necessarily need to be oncogenic. That's really the story with TROP2. So it is highly expressed in epithelial cells and epithelial malignancies like triple negative breast cancer. And it is the target for the antibody drug conjugate sacituzumab govitecan. Sacituzumab govitecan is a humanized antibody drug conjugate. It is targeting TROP2, and it is linked with a payload SN38, which is actually sort of the active metabolite of irinotecan. And so this ADC has been studied in phase 1 in many solid tumors and had really exciting early signal in breast cancer and in triple negative breast cancer. And recently, based on the results of the ASCENT trial, which was a randomized phase 3 study, we've actually seen accelerated approval by the FDA and now regular approval as recently as April of last year, allowing for its use in the second line setting. So I'm happy to do a bit of a deeper dive if we've got the time to just sort of set the stage of what that ASCENT trial looked like.
Yeah, that would be great. I think this is such an exciting development in the treatment of TNBC. If you could take us through the ASCENT trial, I think that would be very helpful.
Oh, sure. Happy to. So the ASCENT study randomized about 500 women with metastatic triple negative breast cancer who had seen 2 or more prior lines of chemotherapy. And one of those could have been in the adjuvant setting. And this was a really heavily pretreated population, a median of 4 prior lines of therapy. Many of these, everyone had seen prior taxane. Most of these women had seen prior anthracycline and alkylator and capecitabine and platinum. So really reflecting that heavily pretreated population that we have in advanced TNBC. The study randomized these women to sacituzumab as a single agent or treatment of physician's choice chemotherapy, which was either capecitabine, eribulin, gemcitabine, or vinorelbine. So again, our typical agents that we reach for. And what was super exciting to see, the primary endpoint of this study was progression-free survival, and sacituzumab was really superior with a 5.6-month median progression-free survival as compared to 1.7 months with treatment of physician's choice chemotherapy. So that was about a 60% improvement in PFS with the antibody drug conjugate. Even more exciting was not only PFS improvement and response rate improvements, but there was a significant overall survival advantage, nearly a doubling in overall survival to more than 12 months with sacituzumab from about 6.5 months with treatment of physician's choice chemotherapy. So highly effective. And that benefit was seen in the overall intention to treat population, which did include some patients that had stable treated brain mets, also an unmet need in TNBC. I think that what is super exciting is not only the benefit that we see in using this drug, but some data that has emerged more recently that TROP2 expression is not a necessary biomarker for selection and use of sacituzumab. So because TROP2 is just so widely expressed in triple negative breast cancer, there was a subset analysis looking at TROP2 low versus TROP2 medium expression versus TROP2 high expression. And in each of those categories, sacituzumab outperformed treatment of physician's choice. So we actually do not need to be testing for TROP2. It is not a companion diagnostic. And this is a drug that works really in all-comer triple negative breast cancer. And I think that's really just so rewarding because our patients are with triple negative breast cancer are so accustomed to hearing that they lack a biomarker. This is just widely active regardless of presence of TROP2.
What a great summary of the data. Thank you for that. And I think that's such an important point you make about TROP2 expression, certainly a question that we get asked a lot and so important when choosing whether or not to treat with sacituzumab. So helpful to know that that's not a factor. Could you tell us a little bit about the sacituzumab related toxicities?
Yes, great point, right? There's always a risk-benefit balance in thinking about this. This is important. So, the main side effects with sacituzumab are risk of diarrhea. And fortunately, the level of grade 3 diarrhea is less than what we would expect to see from irinotecan, but that is still one of our more common adverse events seen. So it does require education, setting expectation, making sure our patients have some Imodium in the house, and communicating with the care team and the nurses in practice so that we can really dose modify as necessary and offer the right kind of supportive care for diarrhea. The other more common adverse event are cytopenias and neutropenia. And so this is an antibody drug conjugate dosed 2 weeks in a row and then 1 week off. There is the option and ability to use growth factor as needed to help support those counts. There are clear dose modification and dose reduction strategies as well. And I wonder if what we're seeing with the degree of cytopenia is also a function of the population that was in the ASCENT trial. I mentioned there was a median of 4 prior lines of treatment. Remember that often these patients with high-risk triple-negative breast cancer have seen anthracycline, alkylator, taxane, maybe capecitabine, maybe platinum, all in the adjuvant setting. So these are patients that are heavily pretreated, and that might also be a component of cytopenia risk.
Great. These are really helpful points for management. And I think we've all gotten very good at, or hopefully gotten very good at managing diarrhea these days. Now, let's move on, if we can, to another TROP2 targeting agent, and specifically DataDXD. Could you tell us a little bit about this newer agent? And I think we have earlier phase data from the Tropion series of trials, specifically the Pan-Tumor01 trial.
Yeah, happy to talk about this. So if we consider the features of an ADC that I mentioned in the beginning of this podcast, that's how I'll define DataDXD. So the monoclonal antibody here is targeting TROP2, and it uses the linker and payload construct of trastuzumab deruxtecan, an ADC that you spoke about so beautifully in podcast 1, and that is FDA approved for the treatment of HER2 positive advanced breast cancer. So you can think of it as almost a hybrid of the TDXD version of sacituzumab, if you will. So these data for DataDXD were presented from a phase 1 study that had an expansion cohort of about 40 patients with triple negative breast cancer. And so remember, in the phase 1 population, these are generally patients who have seen several lines of prior chemotherapy. In this particular study, more than 70% of patients had 3 or more prior lines of treatment. And actually about almost 10% of these patients had prior sacituzumab. So that's interesting, right? These are folks that had a treatment that targeted the same target, but have a different payload, right? So in this study, patients just received single agent DataDXD, And what was really impressive was an overall response rate of about 43%. And when you look at what was the proportion of complete response and partial response, about a quarter of the patients on study had a CR or PR. And nearly every patient in the phase 1 in this cohort had some degree of disease control rate. So either objective response or prolonged stable disease. The disease control rate was around 95%. So, early times, early signal, but I think what gives us great enthusiasm is putting together what we've seen from sacituzumab, seeing the benefit of targeting TROP2, added to the real power of efficacy that we've seen from this linker and payload combination in the HER2 positive space with trastuzumab deruxtecan. So while this was just a phase 1 study of 40 patients, I think it's really encouraging efficacy data, and we expect big things in the subsequent studies that are to come.
That's really exciting. And were there any particular or unique toxicity signals from this early data?
Oh, sure. That's a great point as we're trying to compare agents. So if we think about how does it compare to other anti-TROP2 ADCs, in this phase 1, there were no grade 3 diarrhea or neutropenia events, but it does have a unique, different side effect profile. Interestingly, there was about 13% grade 3 stomatitis or mucositis, right? So something different that we don't typically see so much with the other ADCs, something that we are experienced in managing from our use of other, TKIs and targeted therapies. So definitely need to be aware of stomatitis risk. There was about 4% grade 3 fatigue, and also a rare about 4% experience with grade 3 anemia. But in general, a well-tolerated antibody-drug conjugate, and we hope to see more. Actually, there's a first-line study, randomized first-line study that is launching soon, looking at DataDXD in the first-line setting for patients with metastatic triple-negative breast cancer, irrespective of TROP2 status. So that's something to watch out for, as well as a clinical trial looking at DataDXD in hormone receptor positive HER2 negative breast cancer. So this is something to keep an eye on.
Very exciting. Very exciting. So, we have a few minutes left, and we've been talking about triple negative breast cancer, but I think it's also important that we talk about a new sort of subgroup that we're all starting to recognize, right? And that's HER2 low expressing breast cancers. Could you tell us a little bit about this subgroup and some of the active agents for this group?
Oh, absolutely. I think our language is becoming quite complicated, and there may be a day where we're not able to just use the shorthand of triple negative breast cancer. We really need to be more precise. So not unlike in the ER positive world, where we are now describing an ER low subgroup of 1 to 9%, we are starting to carve out a definition around a HER2 low subgroup of patients. And these are tumors that test either 1+ by IHC or 2+ for HER2, but lack amplification on FISH. So somebody that we would have previously just called HER2 negative, I think now we need to be explicit and define, are we talking about HER2 0, HER2 1+, or HER2 2+? And the reason for this is because if we look back to trastuzumab deruxtecan, the antibody-drug conjugate that targets HER2, we've seen in some early studies that there was a signal of activity with TDXD in tumors that were testing HER2 1+ or 2+. And this was actually quite provocative. So the HER2 low category, whether ER positive or ER negative, had a response rate ranging from about 33% upwards of 54% in those that were hormone receptor negative HER2 low. So that's really intriguing. And the thinking is that, again, you need enough expression of a target for that antibody to bind. And then if you then have a cleavable linker and a payload that's able to diffuse around, you get a little bit of bystander effect, and you can have activity, in a tumor that otherwise really doesn't have HER2 positivity by our traditional definition. So this early observation that our colleague Dr. Modi has presented on previously actually inspired randomized trial DESTINY-Breast04, and that's a randomized study of TDXD versus treatment of physician's choice in patients with HER2 low metastatic breast cancer, either in the second or third line setting. And also building on that idea that HER2 low may be enough for efficacy for TDXD, there's another study called DESTINY-Breast08 that is for patients with HER2 low tumors, and it's looking at combinations of trastuzumab deruxtecan with either targeted therapies like capivasertib or IO agents like durvalumab or other cytotoxics like TDXD plus capecitabine. So a lot of interesting work going on in this space and something to keep an eye on, because we may now need to say, instead of TNBC, really discuss and describe in your notes, and as you think about your patients, what are their biomarkers? What's the degree of ER? What's the degree of HER2? How are you testing it? What's their PD-L1? What's their germline status? What other somatic mutations are there? What's their AR status? So that we can start to paint a picture of what therapeutic options do we have for these patients.
Really exciting and so important to start to really differentiate our clinical populations like that as we start to see these trials in these specific groups. And maybe in our last minute or two, you could briefly mention HER3. We haven't really talked about HER3. Are there drugs coming down the pipeline? Are we looking at trials targeting this member of the HER family?
Yeah, definitely we are. So HER3 actually has a role in tumorigenesis, as you mentioned also nicely in podcast 1. HER2 often dimerizes with HER3, and so it is important for then triggering downstream signaling within the cancer cell. And so there are antibodies targeting HER3 with drug conjugates, and one that has been in study is U3-1402 or patritumab. I'm not sure I'm pronouncing these right. It's kind of a mouthful, but this is a drug actually that we've studied in breast cancer, both in triple negative breast cancer and in hormone receptor positive breast cancer. And it is even further along in lung cancer as well. So looking at HER3 as a potential important target is definitely ongoing. And there are other antibody drug conjugates as well in TNBC that are in development, like LIV-1 and even enfortumab vedotin that's targeting Nectin-4. So I think this idea of antibody drug conjugates is really here to stay and creates so many opportunities when you think about the different ways that we could differentiate by target and by linker and by payload.
Very interesting. And let's put this all together. You've really outlined some very helpful and useful data here. So when you're thinking about selecting agents for your patients, how do you select patients for your agents? Maybe you could give us a little bit of a algorithm as best you can, although things are changing rapidly, for how you treat your patients with TNBC or any of these subtypes.
Oh, sure. Yeah, that's a little bit complicated these days, but I guess we have to keep in mind what drugs our patients saw in the early stage setting. And these days with Keynote 522, a lot of these high risk patients with TNBC would have seen ACT, carbo, pembrolizumab, and then possibly even in the adjuvant setting, additional pembrolizumab and maybe capecitabine. So understanding what their disease-free interval is and tempo of their disease is important. But when I'm faced with a patient with metastatic TNBC in the first line setting, I want to know their PD-L1 status and their germline BRCA status. For those patients that are PD-L1 positive, my approach is getting them a checkpoint inhibitor, getting them pembrolizumab in combination with chemotherapy. We know data suggests that using that checkpoint inhibitor earlier has greater benefit. Although what we really don't know now is how a checkpoint inhibitor in the first line setting is going to behave if a patient saw adjuvant pembrolizumab. So that's a big unanswered question right now. But generally, my first line treatment would be checkpoint inhibitor plus taxane or platinum for those patients with PD-L1 positive tumors. If they are PD-L1 negative, our first line setting, I mean, honestly, a clinical trial is always appropriate. Otherwise, first line is cytotoxic chemotherapy, often taxane or platinum. It is worth noting if that patient has a germline BRCA mutation, I'm reaching for a PARP inhibitor in that first line setting, because I think I mentioned earlier the subset analysis of olaparib, when used in the first line setting for patients with germline mutations, was associated with an overall survival advantage. Once we get past first line, I find that I'm reaching for sacituzumab earlier. Its indication is in the second line setting if patients saw adjuvant chemotherapy. And so sacituzumab is often coming in there in that second line space. Again, obviously, clinical trials are encouraged because we still have a long way to go in improving outcomes here. And I would really strongly urge somatic testing to find those potentially actionable mutations to help even prioritize one trial over another. But I would say that that's sort of my approach to date. Obviously, we're also really invested in research in the androgen receptor and triple negative breast cancer. And at our institution, we routinely test for AR and have clinical trials for patients with AR positive TNBC as well.
Wow, that was such an incredible synthesis of all of the emerging data and treatment approach for your patients. Thank you so much for taking us through that. I know I certainly learned a lot from your overview and the trials that you highlighted here. It's been such a pleasure hearing from you, Dr. Traina, and thank you to everyone for joining us. I hope everyone was able to take away some knowledge from the great points that Dr. Traina made, and thank you again for joining us.
Thank you.
Thank you for joining us today. Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/solid tumors 2. Look for all of our podcasts on your favorite podcast streaming services.